Welcome to the second annual Joining Our Voices virtual symposium on envisioning the future of serious illness care. I am Heather Altman. I am the Executive Director of the North Carolina Serious Illness Coalition, and we are thrilled you are joining for the first of 5 sessions, one each day of what we hope will be engaging and thought-provoking experiences. Today through Thursday's session will be from 8:30 to 9:30 a.m. and Friday is from 11 to 12. Please take a moment to put your name and organization, if you're coming from an organization, in the chat line. You can also use the chat throughout the session if you have questions. We also ask that you keep your microphone muted. If this is your first time joining a coalition event, the North Carolina Serious Illness Coalition is a statewide partnership to advance the quality of life and quality of care for individuals and families touched by serious illness. Throughout collective engagement of our active work groups, we address clinical practice and quality, advanced care planning, caregiver and patient engagement through a variety of communication, advocacy, and education events. You're all welcome to join the coalition. To learn more about the coalition, you can go to our website at ncsicoalition.org, or you can drop me a note in the chat line and I'll add your email to our listserv, and I'll go ahead in just a moment and put the website link in the chat line. So many thanks to all of the coalition members for their work. We work together to develop this symposium. Each work group focused on a special day and panel. And so a special thank you to the Communications, Advocacy, and Education work group who organized today's session. And with that, I'm excited to turn it over to our session moderator, Connie Bonebrake.
Well, good morning, everyone. It's great to see all your smiling faces or names where I know there's smiling faces behind you on this Monday morning. And thank you, Heather. I am Connie Bonebrake, and I'm a population health lead with Humana. And it is my pleasure to be moderating this first session today. Our session is Building Your Village, Preparing for Aging or Serious Illness. To take just a moment and think about what comes to your mind when you hear the word village. Do you think of a set of physical buildings, maybe a collection of houses and businesses in a small rural area? Or does the phrase, "it takes a village," come to mind for you, suggesting that there are challenges in life that require teamwork? Or maybe you think of the concept of the global village, which is the idea that the internet, modern travel, and modern ways of doing business make it possible for the whole world, as it were, to feel like it's local. So regardless of your mental picture of a village, this morning we are honored to have 4 panelists who will undoubtedly challenge you to think about the status of the village that you're preparing, or the village that you're counting on as you age or as you care for friends and family who are facing serious illness. I'm going to get us started by briefly introducing our first 2 panelists, but I want to encourage you to please go to the Coalition's website and look at all of our panelists' bio. So first, good morning, Dr. Zev Neuwirth. Dr. Neuwirth is a healthcare executive who most recently served as the Chief of Care Transformation at Atrium Health, which is now part of Advocate Health. Since 2017, he has hosted an award-winning healthcare podcast called Creating a New Healthcare, and he's authored 2 books, Reframing Healthcare, A Roadmap for Creating Disruptive Change in 2019, and then just this past September, he published a second book, Beyond the Walls, The Megatrends, Movements, and Market Disruptors Transforming American Healthcare. And as a side note, you may want to know that all the proceeds from Dr. Neuwirth's most recent book are going to Feeding America, a national organization working to combat food insecurity. Welcome, Dr. Neuwirth. Next, we have Esther Greenhouse, and Esther is an environmental gerontologist and longevity strategist. She is the CEO of Silver to Gold Strategic Consulting. She co-authored the American Planning Association's Aging and Community Policy Guide and is an industry scholar for the Cornell Institute for Healthy Futures and served as the strategic director for one of the nation's first age-friendly centers for excellence. Her unique enabling design approach is a pillar for AARP's International's Equity by Design initiative and informed the design of the nation's very first elder-focused emergency room. So good morning, Esther.
Good morning, Connie. Thank you for having me.
Absolutely. I'm going to start with you and ask you, could you please describe how prepared you think our villages are for an aging population and an increasing number of individuals facing living with serious illness?
I just want to confirm that you can see my slides.
We can.
Thank you. So, unfortunately, our healthcare systems, our communities, our families, our agencies are not prepared to meet the needs of our burgeoning older adult population and the increasing numbers of people with serious illness. That is not to dismiss or disregard or disrespect the incredible work that is being done, but we are at a critical point where we must look at the status quo very carefully and really analyze what the problems are, because we're facing some extremely significant challenges. And I'm here today to bring some of them to light, which most people are not aware of or underestimate or are failing to take action on. So I'd like to set the stage first with the context. As most of you know, we are in a period of extreme growth with the older adult population, as well as persons with serious illness. Concurrently, we are in a period between 2010 and 2050 where the numbers of potential caregivers are declining. In 2010, some data show that we had about 7 potential caregivers for every one person who needed care. And by 2050, it will be less than 3 potential caregivers. There's an increased demand for services, increased costs of care, and correspondingly decreased financial resources. And we see this on the individual, family, and community level, as well as with healthcare systems, and of course, with state and federal government as well. So my question is, how do you balance the equation? The answer is that the built environment is the missing variable to reduce preventable long-term care demands and costs. In healthcare, the creed is first do no harm. But very few people understand that the design of the built environment is actually harming people. It is exacerbating the demand for care, and it's making the provision of care harder and more costly. So we'll look at why. It's not well known among most decision makers, even very few architects, designers, developers know that people can be artificially move to a lower level of functioning and greater levels of dependency that are preventable by the design of the built environment. So really the status quo of how we design and build our housing, our communities, our healthcare systems, make places that are ideal for the average height male with high sensory, physical, and cognitive abilities, forcing everyone else to adapt. Now, the farther you are from that design norm, the more you are struggling to function. And as we age or our abilities are changed by serious illness, that gap between our ability and what the environment demands grows. And then we're subjected to something called environmental press, which actually pushes us to an artificially lower level of functioning and greater dependency. And this is preventable by a good design. But that's not what typically happens. What typically happens, especially as we age or are faced with the effects of serious illness, is that we are forced into frailty. That means that the design of the environment and the gap between what our needs are pushes us to be more frail. It exacerbates frailty and decline, and that's preventable. The other thing to recognize is that often forced frailty can lead to what I call eviction by design. And that's being forced to move from your home of choice because of the gap between the design and your needs. And in general, we're not talking about anything radical. We're talking about the fact that we fail to design properly for the lifespan and the ability span. The other thing that I'd like to point out is that forced frailty can lead to impoverishment. With the cost of in-home care and also the cost of facilities, where is this money coming from? And lastly, thinking about facilities, while facilities may think they're properly designed for older adults or people who are sick or the provision of care, I find that there's still a significant gap. So at Silver to Gold Strategies, our mission is to enable people to maintain their physical and financial independence as they age or as their abilities change due to illness or disease. Which is why we're developing a strategy, this initiative called Tackling the Caregiving Crisis by Design, to help reduce long-term care demands and costs and address the caregiving crisis. And while I've worked on a lot of amazing projects, I have to say my greatest case study is actually the design of my own mother's home. We designed and built a house with this specific goal to enable her to maintain her physical and financial independence. And we succeeded. She was able to delay moving to a facility by 5 to 7 years, saving the family or the government over $500,000. So we are woefully unprepared, but I think it's exciting to know that there's this whole untapped aspect that we can address, which is the built environment. We have so much room for improvement. And that's what I want everybody to leave with, this excitement that, yes, this is something we haven't been addressing, but we have enormous potential.
Thank you, Esther. I love it that you ended with a sense of excitement. So we look forward to hearing what solutions you may bring forward. Dr. Neuwirth, good morning.
Good morning.
Thank you so much for being with us. And could you please answer a similar question that I asked Esther? How prepared do you think our villages are?
Yeah, so Connie, well, thank you again for inviting me. So I've spent the past few years actually focused in large part on senior care and aging, working with experts in the field. And, you know, I think very much like Esther said, the demographics are increasing. We know actually by 2032, there will be more people in the United States over 65 than under 18. So this is a major demographic shift. And what most people don't realize is it's not a blip. It's going to last well into the 2050s and 60s. And as Esther was saying, with the predominance of older people, and actually the fastest growing segment in our population is over 75 by far. It's literally growing, particularly in North Carolina. It's growing 3 times the rate of any other demographic and any other age demographic. So we have a situation here, and you know, let me take a step back, and then I'll share a couple of solutions. So here's the situation. The system, whether you want to think about the traditional healthcare system or the larger healthcare system in the US, is wholly unprepared for the care of older, aging Americans and infirm Americans. And if you want to understand it from a level of what are the major market forces here, let me quickly share with you. Number one, the payment system is not conducive to care of the elderly. The payment system is predominantly mostly fee for service. So physicians, hospital systems, providers, everyone in the system, pharmaceutical companies, insurance companies, make money. They make their revenue, their margin, by doing things, not by preventing things. And what we know is, and you saw it with Esther's comments, what we know is that what we need is actually prevention, as opposed to waiting till people get sick. So as opposed to waiting till someone has that fall, and then you do that hip surgery, right? As opposed to avoiding that worsening cognitive function, and then having to do some heroic procedures. So the system is really a reactive system, and that's based purely on the payment model. That's number one. Number two, the knowledge base. The system is just not trained, equipped from a knowledge perspective to understand the clinical and psychosocial and just living quality of life issues of the elderly. And if you want to ask why, I've spoken to experts around the country. As you said, I have a podcast which is now in its 8th year. It's the longest lasting healthcare podcast in the country. And I've spoken to dozens and dozens of experts. And fundamentally, the answer might be that there's just tremendous bias in our society. It's called ageism. And it's also called ableism, which is the bias against people with infirmity. And this is just systemic bias, it's institutional bias, and it's built into the system. In terms of the knowledge base, again, most physicians have little to no training, formal training in geriatrics. We only have, in terms of resources, we only have 7,000 geriatricians in the country, which is, most of them are academic. So that means that literally only half of them actually really are practicing medicine. So that's literally 3,000 geriatricians for the entire United States of America, which is absolutely ridiculous. And it's getting worse. What most people don't understand is that physicians are not going and doing additional training in geriatrics or getting boarded in geriatrics. It is more time, it is more training, it is more money that they have to spend. And on top of it, if you actually get boarded, try to understand this. If you become a specialist, you've already trained in family medicine or internal medicine or some other specialty, then you spend another year or two training in geriatrics, and it's a full-time training program, you will actually get paid less as a subspecialist in geriatrics than an internal medicine physician. Geriatricians are the lowest paid doctors that I'm aware of in the country. And if that's not ageism, and if that's not ableism, I don't know what is. So that's the backdrop here, if you want to know the big mega forces. Now, the other part of it is that that what we don't understand, and again, we're coming to understand this. We talk about the social determinants of health, and everyone sort of talks about it as the other 80%. We know that most of the issues that we all face in terms of outcomes are largely non-clinical. And we call them these non-clinical factors, the non-clinical determinants of health. What most people are unaware of is some of the research which is demonstrating that a lot of it has to do with so-called contextual factors. I don't know anyone. Well, let me just say this. There are very, very few people in the country, very few doctors, very few institutions, provider groups that actually even know what contextual factors are. It's been studied for 20 years. It comes out of the VA. And these are factors that literally change day to day that impact health outcomes. And it could be impacting literally up to 40% of health outcomes. And this is research that I've come across. And when I ask the question, I don't even, the fact that I didn't know this until recently, and I came across it, and no one knows about it. And again, why? All the fundamental market forces that I just outlined for you. Now, having said that, I think the positive here is that we know what we need to do. We know that as we get older, as we become more infirm, there's the 4 M's or 5 M's of geriatrics, right? So it's it's your physical, right? The medications and understanding the medications and the chronic diseases. And by the way, we know that over 65, 70% of people over 65 have at least one or two chronic diseases. So this is not the minority, this is the majority. This is just the reality. And so understanding those illnesses, the chronic disease, understanding the medications, understanding polypharmacy, understanding dosing, this we know about. We know that mentation, and again, if you look at the numbers, if you look at the science, we know that there is cognitive decline, especially after 75. And it's highly prevalent. I was actually shocked when I looked at the literature to see the prevalence of cognitive decline. Now, the good part is that we actually can screen for it, which, by the way, most physicians do not screen for it. And actually, there's emerging treatment for it. So we know that. And then there's the issue of mobility, right? Another M. And then, of course, there's the whole issue of meaning and purpose in one's life. And so we know what we need to do. We just need to do it. And in my research, and again, you mentioned the book I just published, Beyond the Walls. So Beyond the Walls is really that. It's getting beyond the walls of our medieval, and I actually use this term, our medieval healthcare delivery system. I've spent now 40 years in healthcare, and nearly 40 years. And I will tell you that we have lived through the dark ages. And I'm happy to, I wrote a book about it called Beyond the Walls. Now, Beyond the Walls is actually how do we get beyond the walls of our medieval system? And I have at least, out of the 9 chapters in the book, I would say at least 3 are about senior care. And and it's not hypothetical, it's not theoretical. What I do is I look at these different aspects of care that seniors require, and then I demonstrate organizations, and some of whom we're going to hear about, and we just heard from Esther as an example, but organization after organization that have said, no, we can't do this anymore. We have to actually take care of older Americans appropriately. I mean, think about this. If you're 85, and again, as a practicing physician and as a physician in the system for years and decades, I've actually sat in exam rooms and watched, and I don't know many people who do this. I've been doing this for decades, sat in the corner of exam rooms and watched how older people get cared for in the clinical exam room. I'll tell you something. I don't know if I feel worse for the individual patient, for their family member, or for the physician, because it is just terrible. The system is not equipped. If you're 85, you've got 8 chronic medical issues, you're in a wheelchair, you probably are on 12 medications. You walk into that same exam room as a 35-year-old or 45. There's nothing different. Same doctor, same staff, same protocols, same resources. In what world does that make sense? And so there are organizations that, again, just to name 1 or 2, and then I'll hand it over. ChenMed, here's an organization that said, no way. We're going to actually provide care, customized, specialized care to older Americans, and they completely changed their model. And this is what I write about in the book, which most people, almost no one is aware of. This is the way to the future. There's 2 requirements. One is there's digital tech. There is no way we're going to solve the problem in aging without state-of-the-art digital technology. And I could speak more about that. In every single case I've examined, they use state-of-the-art digital technology. The other lever is business model transformation. You cannot use the same business models. Those are the 2 levers. And ChenMed is this example. They basically use state-of-the-art technology. They made their own electronic medical record system. They don't let the doctor try to look up what to do in this case. They've built these protocols, state-of-the-art evidence-based protocols, right into the system. So the doctors and nurses and teams literally have the information at their fingertips. In fact, so state-of-the-art, they actually built a tech company. Get this, they built a tech company. They have more software engineers than they have doctors. More software engineers. And what these engineers are doing is creating an electronic system that takes care of the elderly, that supplies the information, the data, all the resources. So it's not like someone looking it up on a piece of paper. And then on top of that, they changed their business model. They do not accept fee for service. They will not do that. They are capitated Medicare Advantage. So they get the funding, and then they take that money and they build a system of care that is highly proactive and highly preventive. And again, that's one example. One quick other example is Papa Pals. So we know that loneliness and social isolation are epidemic in the elderly. We also know that it's serious. It's not just, it'll break your heart because it's so sad. that the elderly are alone. It actually is it's a correlate to dying. If you have chronic loneliness this year, you are 26% more likely to die this year because of chronic loneliness. It is so serious. The Surgeon General, of course, as many of you know, wrote an entire book. This is the Surgeon General of the United States of America, wrote a whole book a couple of years ago about the issue of loneliness and not just in the elderly, but largely in the elderly. And so there was an organization called Papa Pal, which is still up and running. Again, state-of-the-art technology, completely changed their business model. And what they do is they bring younger people into older people's homes on demand to help them with just taking care of things, just to hang out with them, to address the loneliness factor. And I could go on and on and on and share. Again, I have recorded in-depth analysis of literally dozens and dozens and dozens of solutions that exist out there. So my message to the healthcare system is you don't have to make the stuff up. Now, yes, there's always going to be new stuff coming up, but there is so much that already exists that we could adapt and adopt and bring into the healthcare system. And yes, take appropriate care of the elderly and aging, as opposed to now leaving families really alone. Thanks, Connie.
Oh, thank you. Thank you. If you all, I want to remind you, if you've got questions for Esther or Dr. Neuwirth, go ahead and put them in the chat. Heather is monitoring the chat, and we're going to get to questions at the end. We're going to now move into sharing two specific examples of village building that's going on right here in North Carolina. So I want to introduce you to our next two speakers. Neil Shaw is a former hedge fund manager. Good morning, Neil. And he is now a social entrepreneur after experiencing a deeply personal situation with caregiving. Neil is motivated by creativity and humanitarian progress, and he has co-founded and serves as the CEO of Care Yaya Health Technologies, which is a tech startup and an applied research lab focused on enhancing care delivery. Its flagship product is a technology platform that lets people quickly book experienced caregivers that are uniquely all students in the healthcare field, helping expand the care workforce amidst a critical caregiver shortage. Welcome, Neil. Secondly, Maria Sticati is a licensed clinical psychologist. Good morning, Maria. She has been specifically trained in neuropsychology and dialectical behavioral therapy. She has lived in the Piedmont of North Carolina for 32 years. She's the co-creator and current board member of the Traditional Dance and Music Retirement Society. Recently, a partner organization was formed called Four Hands Development Cooperative, and we're going to hear about it. I'm so excited. It is a housing cooperative that proactively plans for the fragile phase of life, death, and maintaining community and dignity. Good morning, Maria.
Thank you, Connie. Good morning, and good morning to everyone else. It's lovely and reassuring to see so many people attending this early morning symposium. I'm delighted to be here, and we're going to hit the high points. I really appreciate what Esther and Zev have said about what's happening. It's really a revolutionary time, and this community that I am a part of, and I'm going to share some slides with you here, has been in motion for, well, it depends on where you start counting, but for about 14, 15 years. And we are fortunate enough now to have 90 acres of land under contract. And what we're going to talk about today is an essential core component of this intention to live together until we die. If you want more information, let me just point to this website, fiddlehead.coop, C-O-O-P. That will take you to a very sparsely developed website, but that will take you to the other sister program that we started years ago, nonprofit, that will give you much more background and history. So we're going to touch on, first of all, what this 90 acres will look like, because that's what people want to know. 152 up to 152 dwelling units of different capacities, community center, this is the heart of the community. I want a small house and my living room will be in the community center. So much of our intention is to be socially connected, and both Esther and Zev have just given us reasons why. Still under development, the design, we're in the zoning process right now, so there's a lot that I can't tell you, but we will design for elderly people, not an elderly exclusive community. We want to be age diverse. We want to be as diverse as we can be in all ways, but we are working very hard with all the entities that we have to deal with to describe this continuum of care that we insist on. And we have had to come back. The first contractors we talked to said, well, no, you should build that family care home later. Build the community center in the second phase. And we said, no, we need that first because of the psychosocial aspects of aging in place, dying in place is what we say. And people say to me all the time, now don't say that dying in place thing. We're going to die together. We want to stay together and reap the benefits that we can actually put on paper. We can demonstrate in research, but then there's all the intangibles. We've used this as one tool. We have many tools and Plan Your Lifespan is one way to look at all of these components. For myself, what do I want? Again, a lot of people say, well, I'll figure that out when I get there. This is a community of people who want to be a bit proactive and have more choices at times of critical junctures. You know, I want to plan what my living space looks like, as Esther has such tremendous expertise in doing, so that I don't disable myself. So Plan Your Lifespan is a good tool. We know that 25% will need 2 years. Here, the research is paid care. We want to be able to do as much as we can for each other. This 2 years of paid care, right, is a cultural evolution in our country where we no longer care for our elders in multi-generational homes, especially in white, more affluent America. So we know there will be need. We also know that there are ways to do that, both paid and unpaid. And I could talk for 15, 20 minutes about each one of these bullets. We have had care teams running in our little limitless community, which really is a creative arts community, dance, music, all kinds of arts. You don't have to do those things to be there, but you have to take interest in being creative across the lifespan. So care teams, I'm sure that many of you know about the existence of care teams, informal, web organized ways to address specific needs for people who can't care for themselves or need help for 2 weeks or whatever it might be. Part-time care home, care in the home, professional care, all the aspects of care that Zev has just talked about. We want to build that in. We want to have the structure that can allow me to go through whatever phases of fragility. And you don't have to be old to experience fragility, right? Chronic illness. This is not just for old people. This is a community that wants to recognize healthcare needs, psychosocial needs, and address them. 6-bed family care home, I already mentioned, would include some of these components. And it's a home. It's not a hospital hallway. And that's another revolutionary psychosocial understanding of what we actually need. I want to point out to here universal training, which is not just cross training. It's training those individuals who are a team to do everything from laundry to as high a level of physical care as possible with some sort of nursing monitoring of medication. So universal, this builds teams. This builds, again, working together. It's not just how we live, but how we work with and honor those who will care for us. So this is a busy slide, but I wanted to share it because it, if you can see it, make it big enough, it points out that we have so much more technology. As Zev said, we're not going to do this without digital tech. But the digital tech is there, and COVID pushed that for good reason. It was worthwhile in terms of finances and care. So monitoring in the home, doing various sorts of communication, health monitoring by remote speakers, etc. There's a lot of ways, and there's more in this nature.com article, a lot of ways that this is beginning to happen. There are some barriers in terms of providers, in terms of people's willingness to have monitors in their home. We also want to have health professionals, not who have an 24/7 office in our community center, but have a setting where they can come, or a person can go for telehealth to have privacy of any kind. We'll build that into the community center. Transportation is a major issue as people become older. We will coordinate transportation for people who need to go away. And then there's hospital at home. This is a whole 45-minute talk that is so exciting. And finding partners to work with us will be essential, of course. And so one last image here, what we have done, and it's pay for service, fee for service, as I've said. Go to the hospital, get your care, go back to the hospital for follow-up, see somebody in a clinic or office. And what we're talking about is getting what we can't do at home, and only that, in an acute care facility. And then as much as possible, a lot more early discharge of individuals who can get care at home. That's what our model will be. And then the necessary follow-ups, whether virtually or in person. And we hope to do this hybrid in between, where an MD, OT, PT can come to us for scheduled appointments. So all of that to say that really what we want to do is to be able to be together, have a high quality of life, while we recognize that we're going to age, we're going to become frail, and that there are other people who may want to live in this community who are young, who also may have chronic illnesses, because it's just going to be on the table. So again, I could say a lot more. And if you're interested in finding out more about our community, Fiddlehead Corner is the name of the community itself, the buildings that will become the community on the land. But if you go to fiddlehead.coop, you'll get more information. And I really appreciate your time. I'm not sure if I've gone over my 5 minutes. I probably have, just a tiny bit.
Perfect.
There are
You're
lots
perfect.
Oh, good. Lots of resources that I've attached here. 2 pages of them that are websites that I've either referred to or I would have liked to have shared. So let's see. I think I'm stopping my share. It seems kind of pokey though. Are you still seeing my screen, you guys?
We are.
There
It's
we go.
okay. I want you to add a place where I can go take fiddle lessons, because I think I would like to fit in that circle that you just shared. Thank you.
Let me tell you, in that community center, we will have music rooms for teaching, because there will be many, many musicians there who are teachers and want to share. We hope to have school programs for kids coming in. The sky's the limit. Thank you for the opportunity so much.
Thank you so much. Neil, are you with us?
Yes.
Oh, great.
All right.
Thank you so much. And we are looking forward for you sharing about Care Yaya.
Sure. Okay, let me share my screen. Thanks for the opportunity. Okay, can you guys see it?
We can.
Yes. Okay, great. So yeah, thanks everyone for the time. And I'll try to zoom through the slides. I just gave out a longer presentation to the governor's Committee on Aging. So I'll shorten for this audience, but thanks for taking the time. I'm Neil Shaw. I'm the co-founder and CEO of Care Yaya Health Technologies. I actually started it after a deeply personal experience as caregiving mid-career. I was in my mid-30s and took care of my grandfather through dementia, kidney failure, and end-of-life care. And then right as that ended, took care of my wife through serious illness and several years of cancer treatment. And I basically realized, I'm not going to mince words about it, I think the care industry is broken, and I think we're heading for a societal disaster, which was really what motivated me to do something about it. So to quickly kick it off, this is how fast somebody's getting dementia in this country. Like every time I clap, and then over the next few years, it's going to go like this. I think that there is a huge crisis coming, and I don't think that we're really aware of how bad the crisis is and how bad it's going to be on society. So I'll quickly zoom through these points. There's a crisis, there's a broken care industry heading into the crisis, disproportionate impact on women and minorities, and here's our solution. But I encourage other people to come up with solutions too. The reason for the crisis are threefold: aging population, social isolation, and impact from COVID. Dementia probably skyrockets after 75. If you do the math, after the baby boom, the boomers just started turning 75 in 2021. And I think this whole decade, we're going to see a very large portion of that. I think Zev pointed to that as well. Increases with loneliness. We just came out of a few years of pandemic. So dementia probably triples with loneliness. And then damage from COVID infections. Even mild infections are resulting in an early stage inflammation that is very similar to early stage of Alzheimer's dementia. We saw this from the Spanish flu. 1917 plus 5 years, skyrocketing incidence of neurological disorders across the world. And I think we're about to head into that. So there's a huge danger and opportunity here. Demand for care is going to rise. There's already workforce shortages in home care and healthcare, and it's going to lead to major disparities in access and worse outcomes for the entire population. And I think the opportunity is to bring more people into home and healthcare, lower costs, expand access, and then bring a lot of technology into the mix. So I'll skip over some of this stuff just in the interest of time, but basically 80% of people who need help can't get help. Population's rising. The fastest cohort of the rising population is 85 plus, and then the second fastest is 75 plus. So I think this is where the care needs really skyrocket. And I think people who are predicting the aging of America, I think miss the point that it's not when people turn 65 that they need a lot of care. It's when they turn 75 and 85. And I think we're just about to hit that wave. And I think we're going to need an army of caregivers to combat this crisis. And here's what we have: tremendous caregiver shortage. Actually, North Carolina is one of the worst states in the country. Half the caregivers per capita as the country average. So I think it's also just like relative to other states, I think it's a disaster. I think the real break here, and I've observed this firsthand, care agencies are not serving this need. And I've talked to all of them about it. I think the system is filled with great people, but it's actually, unfortunately, just a broken system. The cost is way too high, 25 to 35 bucks an hour, and the pay is way too low, 11 to 13 bucks an hour for caregivers. Half of what you're paying is going to the caregiver. And I think people start these with good intentions, but they really enter a broken system that limits how they can operate and really maximizing for economies of kind of local economies as opposed to economies of scale. Cost of care skyrocketing. It's over 60 grand a year to get median cost of in-home care right now. So if you think about who can afford that, 2 to 5% of society. What can people do? Sorry, I have to skip some of these slides. Assisted living, not serving it, absolute disaster. 50,000 on average for assisted living. In the interest of time, I'll just skip over to basically what happens, right? Like health disparities. If you can't get care or help at home, it's actually a disaster. Zev, to what you pointed out, loneliness, it's a new heart disease, right? If you don't have help, it's the equivalent of smoking 15 cigarettes a day. The toll on family caregivers, and I'd say experience this firsthand, physical and mental health toll on society is going to be a disaster here because when you can't get care, it's going to fall on the family members. And I think that is a disproportionate issue that affects women and minority populations. I'll skip over some of this stuff in terms of stats, and I'll kind of get to what I think is really the point. Everybody needs access to care, and what's it going to take? And here's our solution. What we did is we built CareAI.org to bring more people into home-based care and healthcare, lower costs, expand access, and bring a lot of technology to improve outcomes. So here's our team. Skip over this stuff. Here's our board of advisors, a bunch of people from health insurance plans and hospital systems. Here's the opportunity we saw. There's 75,000 free health career college students across the state currently not participating in the care economy. Many of them are doing Uber or DoorDash to make side income, and they will work flexible hours in a gig economy platform. And they really want these experiences as a pathway to a future healthcare career and graduate education. So here's what we built. We built an online registry where people can book care in less than 2 minutes, free to use. It's maximum health equity. Pay the caregiver directly, 15 to 18 bucks an hour. So it's half the cost of traditional agencies, and expanding rapidly across the state. Basically, we tailor profiles, have a safety first matching platform, background checks, verification of enrollment at school, and interviews. And critically, the students get 100% of what the family pays, which is just an awesome, kind of feel good for both students and families. It's mostly companionship right now, and over time we might enter higher acuity, but there's enough of a companion care need. And critically, weekend and overnight care is available at no surcharges. So I think that's another thing the care industry is completely not solving. So 15 bucks an hour versus in our area of Raleigh-Durham, it's over 35, 40 bucks an hour to get weekend and overnight help. So since we launched it early last year, it's now skyrocketing. We have, and I think this number is a couple months old. We have over 5,000 people on it. We're at most major universities across the state. So it's growing like a weed. And really the students are coming to us from professors and pre-health advisors that we collaborate with. This is probably the most feel-good thing of running the whole thing, is just the intergenerational relationships across society are skyrocketing. It's really amazing and awesome to see. I'll skip over some of these slides, or actually maybe I'll just pause the presentation because I have too many slides. I'll turn it over to Q&A. But yeah, thanks for the opportunity, Connie, and I really appreciate it.
So much good information. Thank you. Thank you, Neil. We're going to end with a question that I'm going to let each of you all respond to, and Zev will come to you first. For all of us listening, as we think about building our village of support, what actions do you recommend be prioritized in the immediate future? Zev.
Yeah, so just, one point, Connie, one of the things as we talk about ageism and the issues that all of these speakers have been speaking to, and just fantastic, hopeful message, I think we cannot forget about the issue of racism as well. And as bad as the situation is for white elderly, it's much worse for Black elderly, and for numerous reasons. And this is not just conjecture, this is the statistics, and this is the reality. And of course, we're not only just racism, but the whole issue of the poor, and we haven't really touched upon that fact. Healthcare has contributed to I think the demise of our savings, because we're that untold tax as you spend decades working and your family's working as employees. We know that healthcare now is $24,000 a year, $24,000 a year for a working family of 4 people. It is almost mind-boggling. So by the time you actually reach your golden years, number one, you are sick because of the sick care system, as Neil pointed out, and you don't have the money because of all the money that you spent over decades paying for healthcare. And again, this is not conjecture. This is actually quite real, and the numbers are devastatingly shocking. But I did want to just make sure that we touched upon the issue of disparities and equities along racial lines, because I think it's just so important.
Thank you. Esther, immediate next steps or prioritizations, what would you suggest? We can't.
Yep, sorry.
Okay.
Okay. So I think the immediate steps are to focus on developing an understanding, and this is often through education, of how you can leverage the built environment. Zev talked earlier about the business model. On every level, the individual, family, community, and the healthcare systems level, we need to be looking at the financial implications and doing a cost-benefit analysis. Give you one brief example. With my mother, we put in a bidet seat for her, and over 7 years, that $1,000 investment saved the family over $30,000. And she never had a UTI, and she had dignity and agency. Think about from a provision of care perspective, if you have features of the environment that are enabling the care receivers to do more for themselves, how does that impact your business model? The other crucial thing is partnerships. Regional healthcare systems must form intentional health partnerships with state and local government based on leveraging the design of the environment. And again, the built environment is, as Zev was talking about social determinants of health earlier, it is a social determinant of health, but we misunderstand what physical design of spaces can result in and the impact it's having now. So thinking about healthcare systems and state and local governments, both are significantly impacted by the number of frail elders and persons with serious illnesses in their communities. And at the same time, they're at the mercy of the number of care providers and direct care workers. I'd also say that, keeping with this theme, build your village. Recognize that municipal governments are key to addressing these issues. So are family caregivers and people who receive care themselves, as are healthcare providers and builders and developers. We need to work together. And there was a question in the chat, and I just want to mention, I was recently asked by the Bipartisan Policy Center for what are some of the key issues between health and housing. And this is it. It's understanding that having a wider doorway can make all the difference between you being able to remain at home. Having a 0-step entry or a 0-step shower can enable you to independently age in place or successfully age in place with assistance. So we're not talking about anything radical here. We're not talking about rocket science. We're talking about thoughtful design that works for people of all ages and stages, but makes the crucial difference between where we are today with the status quo and what we need.
Maria or Neil, do you have anything to add about what actions you recommend for the immediate future? Thank you, Zev and Esther.
Neil, I'll let you speak first. I'd be happy to talk, but go ahead.
Sure. Thanks, Maria. Yeah, I would say that from my perspective, I see that there's tremendous opportunity for innovation. And I think that society-wide, we should do things to encourage people with ideas to kind of experiment, try them out, get people into this field. As a 40-year-old male, I don't see many, colleagues entering the industry. Actually, when I entered in the industry after my own care experiences, I think a lot of people I used to work with and people I went to school with, I think were like, oh, why are you focusing on that industry? And I was like, well, I've dealt with it myself as a caregiver, and I realize how many people are going through this. So I think first is just raising awareness. I think raising awareness so you can get kind of entrepreneurial mindset people who might be pursuing innovations in other fields to focus their energy on this field, given the tremendous magnitude of the problem, the social impact. I think lowering barriers is another one that in starting even something like CareAI, now that it's taking off and it's spreading into multiple states, it's kind of like easier to operate. But in the earlier days, there were a lot of barriers to innovation in this industry, especially from existing incumbents as well as government. I think that over time now we're forming great relationships, and DHHS invites us onto task forces and steering committees. But in the earlier days, I think it was a little bit harder, and I think that healthcare is a harder industry to innovate in. Home-based care, I think, is kind of this on the cusp, which makes it easier because it's consumer directed as opposed to healthcare like at a hospital. But I do think we need to lower barriers. Otherwise, there won't be enough innovation. And then third is probably funding support. I think there's a lack of funding for innovation in this field. And I think that needs to change. And I think that's going to happen through venture capital or other kind of private investors once they see, some early success. So those would be my kind of suggestions.
Thank you. Maria?
First of all, I want to say that if the 4 speakers today could put their heads together, the wisdom here, the experience is tremendous. I see myself as working from the ground up. I literally want to build a village, and we're in the process of doing just that. Innovation, being consumer driven. I would appeal to all of those people on this call who are in healthcare executive positions or a position where you can say to colleagues, oh, this might be a possibility, as opposed to that's not the way we do things, because it's going to take people like me out there, plodding along for years to come up with a feasible way to do this. But it's also going to take people who are already in positions of in organizations where they can speak for change. And whether it's in a healthcare system or a small local clinic or family care home, whatever it is, we all have to think out of the box. And obviously it's past due, given what everyone has said. But I believe that it's doable, that we can do this. And, you know, if I were going to appeal to anyone, it would be to state and local governments who say, no, that hasn't been done before, or no, we can't do that, or you have to go through a lengthy application process in order to be able to do that, which puts a damper on innovation. So I want to thank everybody for being here today and keep these possibilities. This is really an inspiring talk for those of you who are thinking, yeah, it is broken. I can see it in my day-to-day work. It is broken. What can you do to help us all fix it? Make it better. Thank you.
Thank you. And I want to add my thank yous to all four of you for being here this morning, for sharing your solutions and your enthusiasm for moving forward and building villages. Sue, Heather, do you see any questions in the chat that we didn't touch on, or anything else that you want to add before we end our hour together?
There was a really interactive discussion on Chatline. We have a lot to solve. There was a discussion about what can we do at the state level, the national level, the global level. How can we do things in terms of innovation and as well as legislative changes, including how do we address the caregiver workforce and what role does immigration play in bringing more caregivers. So I would also highlight, so this is more of a recap of the chat. There's a number of resources. I want to add my thank you to the panelists, and a number of them put their own links to websites up on there, and we will be sure to add that to our website. And you still see it coming through the chat line. I know for myself, both as a professional in this field and as a family caregiver myself, and as an aging adult myself, I think it was Zev that made the point. So many of us come to this through our personal experiences that now inform our professional efforts. So I don't know if there's any other questions that we can touch on really quickly in the next few moments, but I'm just sort of seeing the chat blow up with lots of comments. Esther, I see your hand raised.
Yes, I was really glad that Zev talked about the importance of digital technology. And I'd like to piggyback on that and caution people that while that's very true, often people are under this misconception that robots are going to save us and provide care at home. And I encourage people to remember that we shouldn't be putting all our proverbial eggs in the basket of technology saving us when we're not doing the basics, like having zero-step entries and wider doorways and appropriate lighting. So these things have to work together.
Wonderful, wonderful point. There is the good news and the complicated news. There are so many ways that we can address aging comfortably, thriving at home, thriving in our communities. And it's a chocolate, vanilla, strawberry question, and the answer is all. What can we do in our homes to make them more accessible? What can we do with our technology to make sure we're maximizing it? What can we do with our policies to make sure we are not stifling innovation? And what can we do with our caregiving workforce on all levels to make sure it is honored, respected, well compensated? I do want to say, with our 1 minute left, I want to put my love out to the panelists for such a great program. And there are 4 more sessions. We have a session each day of this week. Tomorrow's session will be on Veterans Affairs Caregiver Support Program. So really diving into lessons learned and opportunities around the caregiver space. On Wednesday, we'll be exploring the use of video in advanced care planning. On Thursday, we're going to be looking at From Books to Bedside, the Art of Serious Illness Conversations, which is all about how is our healthcare education system preparing students in a number of different medicine, nursing, social work, pastoral care to go out and be able to better support individuals and families. And then on Friday, Empowering Tomorrow, Navigating the Future with Advanced Care Planning with Marisat Hassan. What's really the future of advanced care planning and how can we support each other? So with that, we are at 9:30. Thank you, everyone. Connie, thank you. And the Communications, Advocacy, and Education Work Group, thank you for this amazing panel with Neil and Maria and Esther and Zev. And thank you all so much for joining us.